Okay, so we are in Huga Studios with Dr. Covington, who is the CEO and founder of Abundant Health and Vitality Associates. So we really appreciate you coming in.
Thanks for having me.
You can just start out with telling us a little bit about you.
So I am a board-certified internal medicine physician. I am also a bariatrician. A bariatrician is a doctor that subspecializes in weight loss and weight management. So I chose in residency to do obesity medicine full-time. I originally was on the track for primary care, outpatient practice, and started realizing that majority of my patients with diabetes and high blood pressure and high cholesterol, their underlying issue was actually their weight and their diet. So I could never cure those diseases if I didn't first approach the weight. So I chose to do weight management full time. I was Novant's very first bariatrician in Charlotte, Matthews, and Huntersville.
Oh, wow.
So that tells you a little bit about how old this practice is for the medical physicians. Bariatric surgery has been around for years and years and years, but the idea of a outpatient medical doctor doing weight loss is a little newer.
Right.
So after doing that for a little less than a year, I decided that I wanted to have a little more control over my practice and to create my own establishment.
That's awesome.
That's actually really amazing, because I think given like the stereotypical diet of African Americans, it does not lend to being too conscious about your weight, or it's there's these stereotypes of be thicker, those kinds of things in our community that it's not a bad thing, but it's not necessarily always the healthy thing. And so I think it's good to just create some balance in that and help people to figure out, whatever your body type is, that's what it's going to be, but then how to be healthy about that.
Yeah.
Exactly.
Yeah.
There's some genetic components in how we look, but we can always be a healthier us.
Absolutely.
Let me ask you this. With you being the first, have you ever had to fight against any discrimination or any marginalization just as a female doctor?
I would say definitely. So I've been in both hospital systems here, and I think they're fantastic. So it's nothing against any particular hospital system, but you don't only deal with discrimination with your colleagues, but sometimes with patients. And it's not only patients who look different than you, it can also be patients who look just like you. I always say that the biggest discriminating factor that I've suffered is actually my age, more so than gender and more so than race. And that's surprising to a lot of people. When I walk into a room, you can tell that I'm young. I have the young, healthy glow, which I hope to have for the rest of my life.
Forever.
Yes, girl.
She's talking about the black girl magic glow. For the people that are listening, that's what she's describing.
So it's obvious that I'm young. So that's typically the main discriminating factor is, are you old enough to be a doctor? How long have you practiced? And then to be one of the youngest private practice physicians in North Carolina, that has another barrier as well.
Yeah.
Not only am I a physician, but I'm also the boss of my clinic. So discrimination can come in a lot of different flavors. It's not always race. It's not always sexism. That is definitely there. But the biggest for me has actually been the age gaps. When I started working in my first position, the physicians there, there were some that were 20, 30 years older than me. So the cultural, the traditional differences in just medicine, how it's changed in 30 years, and then being much younger, that was something that I had to adjust to.
Wow.
So what are some of the mental health concerns that you come across with some of your clients, patients?
There's definitely quite a few. It's no secret that for the bariatric surgery path, and that's not the only path in weight management, it's one of several, but there's no secret that to go down that path, you have to go through behavioral health. So you have, can be anywhere from 3 to 6 months where you're spending time with a psychologist, and just going through, why are you getting bariatric surgery? Are you mentally healthy to do it? Have you any history of suicide? Things like that. And that's just to be sure that individuals are able to adjust appropriately after bariatric surgery. It's a huge life decision. It's a huge change. And there can be increases in depression, increases in alcoholism, increases in eating disorders after surgery. So we definitely see things there. You see issues with self-esteem. You see issues with, things holding people back from their dreams and their visions and things like that. But then you also see some of the organic mental health diseases. So we see eating disorders, bulimia. We see night eating disorders, night syndromes, things that you don't really think so much about. Binge eating disorders. So we definitely have to weed through those. Some obsessive compulsive disorders. So there's quite a few. There's higher risk of depression, anxiety in obese and overweight individuals as well. So
what about, I'm a self-proclaimed emotional eater. Do you see any of that?
I will say that is one of the stereotypes in obesity management. Everyone thinks that it is the person who's sad, they're eating a bucket of ice cream. That is actually not as common as we think it is. Usually when people are, definitely there's a component of emotional eating, but that is not the majority of people who deal with their weight. For a lot of people, it's actually the complete opposite. When they're sad, when they're depressed, when they're going through something difficult, difficult emotions, they tend to not eat. So that's one of those stereotypical things. I don't see usually the emotional eater. And some of it is probably because I am a physician. I do see more actual diseases. So, the diabetic who's on insulin who now has an overriding hunger and they're craving sugar. The PCOS patient, some of the other diseases that can cause obesity, Cushing's disease. So it's very rare that I see the typical person who just, I just can't stop eating. That can happen. A lot of times it is because of something already in the diet, but a lot of times I see a different type of profile of patient.
How hard is it for someone to kind of acclimate to their new body? Once you've lost a significant amount of weight, because I think I've seen it in television and things like that where people are like, oh, I still dress for the body I used to have. And so what does that process look like in your work with patients?
That is a fantastic question. And I can actually speak to that firsthand. So I lost 80 pounds, and when I lost 80 pounds, I still saw myself as very large. And I look back at pictures now, my bones were sticking out, and people would say, oh, I can see your ribs. And I was like, oh, I need to lose 20 more pounds. So it can be a very difficult process to see yourself in a new body, as a new image. With patients, that can be that can be a reason for weight regain, to be honest. I think the worst case of weight regain that I ever saw was a patient who lost 100 pounds and just had issues with adjusting, not to just how they saw themselves, but also how their family members saw them. They dealt with a lot of guilt. They dealt with a lot of, people saying things that were not as nice. And they dealt with a lot of feeling like they had to be a part of traditions and cultures that led to obesity. So that's definitely an issue in weight loss and weight management. And I wish I had an answer for how to get people to adjust to a new body. I can say that I was very guilty of not really adjusting to a new body at all.
Wow.
And if you still see yourself as an overweight or obese individual, you will get back there with your own self-defeating thoughts. If you look in the mirror 80 pounds later, 50 pounds later, 100 pounds later, and you keep subconsciously telling yourself, I'm too big, I'm fat, I'm this, I'm that, it won't be long before you put the weight back on.
Yeah. I just want to add, when I was in graduate school and I was trying to figure out how to put photography and therapy together, I remember a friend of mine talked to me about a photo therapist, I guess you would call it, in New York, who worked with people who had eating disorders, and she would take pictures of them through their process and use that as a guide to kind of help them, I guess, have a externalized view of themselves. Because it's very interesting, even myself, Like I'll look in the mirror and I'll be like, oh, I look like smaller today, but then it'll be another day I'm like, I look a little bigger today. Like, and it's only a day apart. Like I don't know, maybe it's what I'm wearing or whatever, but sometimes I don't see myself the way other people do.
Yeah.
And it's because I'm always looking down or a reflection, and it's never that outside perspective.
Yeah, I totally agree. The self-perception is
Yeah.
very powerful, and it's difficult
Oh,
to,
yeah.
to really comprehend completely.
What led you to medicine? What led you on the course to becoming a doctor?
That's a fantastic question as well. I can't hide from you guys. This is going to be
You're
taking
talking
off,
to two
taking off all the layers.
therapists.
It took me a long time to honestly answer that question because I didn't want the most obvious thing to be the answer, which was my parents were deceased when I was very young, and I kind of felt like that can't be the reason why. That's too easy. But you know what, it was. So I am the youngest of 7 siblings, and there's
a lot of y'all.
There's a lot. We're all blood related, and I love my brothers and sisters. They'll be watching.
Beautiful.
And my parents, there's a lot of large age gaps. So my oldest brother is 22 years older than me, and then the next in line, which is a set of twins, is 12 years older than me. So I was the last, the very last child.
Oh, wow.
I mentioned that to say, my parents were older. My mother was in her mid-40s when she had me. But they both died early, I would say. My mother in her 40s, about a year after I was born, and then my father shortly after her from complications of diabetes. So you kind of grow up with a Superman complex a little bit. I don't want to say that I have that, but I think that definitely played into it. I was very smart. I was very inquisitive. I had older siblings, so you kind of learn how to speak and read and adjust and think, and you get a lot of wisdom when you have older siblings. So I was kind of just naturally on a path to be something. To be something, And so for me, I kind of looked around and said, well, even with the age gaps, everybody's dying around me. Not necessarily my siblings, but your grandmother's obviously going to be a lot older than if you were born when your mother was in her 20s, and your uncles and aunts are going to be older. So I kind of had this thought that there's something that we need to figure out so that this does not happen to us, to the immediate family. So I took it upon myself to be that person to fill in the knowledge gaps. I believe very strongly, like the Bible says, when people don't have knowledge or vision, they perish. So you have to understand things. You can't be ignorant. So I wanted to understand medicine, understand health, understand life, quality of life, so that I could be healthy, live long, and also take care of my family.
I think that's a really beautiful story that I don't think you should, be like, oh, it's this easy answer. Like, I think it's a really, that's the best kind of inspiration to get somebody to do something.
And it's genuine.
Yeah.
I always wanted older brothers and sisters.
I got older and younger, and sometimes they're great, and sometimes they're
not so great.
Not so great. I love you, Kim and Gray. Okay. I did have a question that's just been bugging me for forever. The BMI.
Right.
Like, I always felt like it was based off of European standards, Caucasian standards. Is that true, or is it something that fits across the board for everybody?
No, it definitely doesn't.
Okay, thank you.
And I think that most
you saved Erin.
Because I'm just like, I'll go in and they'll tell me I'm obese.
Right.
And I get it. I probably do need to lose weight for my height. But at the same time, I don't feel like I'm obese,
Right.
So
exactly.
Yeah.
So, and most physicians will tell you the BMI is not perfect. It's used as a tool. It's used as something where when you see your doctor, your primary care doctor, they can quickly look at this BMI and ask more questions. If the BMI is 40, we got to ask a couple more questions. The next step, obviously, is looking at the patient. If they're a bodybuilder with a BMI of 40, they likely do not have an unhealthy amount of fat percent. So as a bariatrician, I do use BMI, and our insurance, I don't take insurance, but insurance codes based on BMI. So we use it and we utilize it, but we have to go a step further than that. So BMI is body mass index, and like you said, it is a weight to height ratio. a healthy BMI in this country would be 18 to 25. So what we know is that, Black individuals are going to have a higher BMI. We are also larger, and we do also have the highest rates. Black women have the highest rates of obesity in this country. So we do have to acknowledge that. But at the same time, is BMI the best way for us to look at our amount of fat? No, definitely not. The number one way to determine if someone has a healthy unhealthy fat, which is what we're looking at with obesity, it's an abnormal accumulation of fat.
Yeah.
Is fat percent. So the number one tool for that would be a DEXA scan, which is, it can be expensive, may not be covered by insurance, but that's the gold standard. And then after that would be your bioimpedance technology. If somebody has a handheld fat thing, it's not bioimpedance technology. Bioimpedance technology is thousands and thousands of dollars.
Oh, wow.
The fat caliper stuff, do I believe that is accurate? Not at all. It's usually, it depends on the user. But that's what I look at in my clinic. I look at how much fat does this person have on their body. For Black women who are curvy, we look at hip to waist ratio. So that can be a better a determination of unhealthy fat, because the good news, ladies, is that if you have large hips, that's actually more advantageous than having that fat around your midsection. So we know that the pear shape is better. Those individuals, they live longer. That's a better distribution of fat. So the large hips, the large butts, that's better than a large gut. No, the quick answer would be BMI is definitely not the most accurate, but we do use it, across the board, just to have a quick assessment so that we can ask additional questions.
What about, and you may or may not be able to answer this, but the therapist in me too says, what are we examining? Just our relationship with food. So I've worked with clients, and just even my own self-examination, like it's rare that I've met people that are eating when they're hungry. And then going to other countries where I've seen hunger and seen people physically hungry. I wonder how much discussion with your patients is there around this relationship with food and discerning, am I hungry from these other emotions? And I also read somewhere too, oftentimes when we think we're hungry, we're actually thirsty, and we're actually dehydrated. So I just wanted to hear your thoughts around that.
Okay. So I approach that a couple ways, and I want to be sure that I answer your question specifically about, food and the relationship part. But where I actually find that people make the most mistakes is food and knowledge, meaning there's all these different diets. Studies have been done on all the diets, and it has showed that, technically all of them do work. All of them do not work for everyone. But if you are trying to do my diet, it may not work for you. If you don't understand macronutrients and balance, if your carbohydrates are a lot higher than your healthy fats and your protein, you're going to be hungry. Carbohydrate is a macronutrient that drives hunger. It causes the reward system in our brain to light up. We love sugar. So where I start in my clinic is looking at what people are eating and educating them on food and nutrient balance, and also finding out about their physiology. That's where labs come in, that's where tests come in, that's where diagnosis come in, make sure that we're not missing a disease. If you come in and you have been gaining weight, you're a female, you're childbearing, hey, you may be pregnant. There's no point in us talking about your relationship with food when obviously you're driven to hunger. You're supposed to be.
Right.
So, the first thing with food and nutrition is that it does have the ability to turn on gene sequencing and to make our brain cause us to make certain decisions with what we eat. So I always start there. And when we start there, all of that, hunger, cravings, emotion stuff actually takes care of itself, because it's not always the emotion. It's that you're sending a signal to your body to gain fat, and it does exactly that. And you're doing that because you just don't have the proper knowledge. And I'll go back, 30 years ago when we took fat out of food, that's when obesity skyrocketed. And it's because the number one macronutrient is actually fat. That's the reason why the body stores it. It's the most calorically dense, and it is the best nutrient for the body to survive on. So, that's not a emotional thing. That's a chemical thing. You took out something that is absolutely necessary in your diet, and now your hormones are all over the place, and your brain is sending you signals that are in support of weight gain and not weight loss. Now, is there an emotional component to eating? Sure. We know that certain foods are going to trigger releases of serotonin, which a lot of the SSRIs and the depression medications are based on. Dopamine, different chemicals, and can we do that with the foods that we eat? Absolutely. But what I find to be the bigger issue are chemicals, processed foods that do the same things.
Yeah.
The people, the people who studied and created these foods, and I don't want to mention anything because I don't want to get sued.
Good, don't.
They knew,
Don't.
they knew that brain chemistry, and they understood that physiology. And they said, if I can release these chemicals in your brain, you will not stop eating. You will be hungry, you will be unfulfilled, and you will accumulate fat.
We're gonna have to talk about who they are after the podcast.
Just not live
right now. Not right now.
Yeah.
But
So I find that to be a bigger issue.
Wow.
And for a lot of my patients, that's a huge relief because they have heard their entire life that they're an emotional eater. They have no willpower. They're weak. You want to be fat. You make bad choices. They've heard that forever. So when they come into my clinic and hear, nothing is wrong with you. We're just giving your body the wrong signal. We can change that, and I will say that I have a 99% success rate for weight loss.
Wow.
That's
And that's
wonderful.
because I'm able to take more time with patients, figure out their physiology, and then give them the proper information, and also monitor them. You're being monitored by a physician who is a specialist in obesity. So, they're relieved when they hear that all of the stuff we see in movies with the person on the couch eating ice cream is not really their issue. That's not it at all. That's a huge misconception. I have a new intern from Queen's University that's been with me for the last couple of weeks, and she's thin. And I asked her a question. I said, if all we had to do to be a swimsuit model was eat 1,200 calories and exercise an hour a day, how many people do you think would do that, and would that be hard or easy? Now, granted, she's extraordinarily smart, so she answered the question correctly. She said everybody would do it, and it would be very easy. Those are the only two things I have to do. So it's beyond that. It's more than that. It's not just what we eat, drink, and how much we move. The physiology matters. The chemical sequencing matters. The type of food choices that we have and what we tell our bodies to do absolutely matters. The set point for our brain and what your brain logs as your normal weight matters. Your genetics matters. So obesity is definitely multifactorial.
God, I felt like that was the gem of the day right there, because even I felt a little relief.
I did too.
Hearing that, because a lot of times we do think, like, what's wrong with my body right now?
Yeah.
Why is it? But I mean, it is the science, and sometimes I really hate the idea of thinking that corporations are abusing us, even though I know it's real, and that they're taking advantage of what, that everybody is like struggling, frustrated, whatever. And so they're looking for comfort and something that soothes them. And so we eat, and we eat a lot in America, like a whole lot. And so it's interesting. Very, very interesting. But,
and we have the option to eat a lot.
That's what I was thinking.
So, you think about carbohydrates, for example. So I know that my profile is a carb sensitive, insulin resistant profile. How do I know that? My father had diabetes. I absolutely love sugar. It does not take long for me to get addicted to it. But it also makes me sleepy, it makes me fatigued, and it gives me, a cloudy brain. So I know for me personally, that is a substance that will lead me to obesity if I abuse it. Some people will tolerate carbs fine. They can have a high sugar, high fruit diet. But I'll use carbohydrates as an example. Fruits are not supposed to be in season year round.
I think about that.
Strawberry and blueberry season is extraordinarily short. It was over a long time ago. It's only 2 months for those fruits. So in the United States, we have access to carbohydrates all the time. In nature, carbohydrates are not available all the time. So I think about What the Health, which I'm glad you guys didn't ask me about that because it's very controversial. I think about those things. And
I watched it. It changed my life.
It changed a lot of people's life. I don't know if it's for the better yet. We'll see. But whatever diet people decide that works for them, I'm always in support of. As long as they have the right nutrient balance, the right chemical balance, et cetera, I'm fine with that. And when I say chemical, I mean for the way that their body is functioning. If you're on a vegan diet and you can't think straight, we need to do something else.
Yeah.
But, you know, the one thing I will say about that movie is that, you know, are those foods in season? Are they available? If Irma came and was catastrophic, all the vegans would die.
Yeah.
So, you know, we have to think about that too. But carbohydrates are not meant to be around all the time. So in the United States, we have access to foods that we shouldn't have access to. So now you're able to give your body something that if we were in Alaska, it wouldn't have. If we were the Maasai, we wouldn't have.
Yeah.
I even think about when I go outside of the country. So I try to get outside of the country at least twice a year. And I always notice that I either lose weight while I'm there, or I'm like, man, I'm eating very differently. And it's because, like you said, the options here. And I'll even comment on it from time to time, like, yeah, there's no bodega, there's no gas station where you getting snacks. You go to the gas station, you get gas, and that's what's available. But here, like, and I don't know if it's the instant gratification, you know, that we crave, where we have to feel like everything needs to be readily made available, but that is something that I've thought about.
Yeah, and it's the demand. So, you know, like I mentioned, 30 years ago, you take fat out of the food, what do you replace it with? You replace it with sugar. You replace it with carbohydrates. So the largest part of our pyramid has always been the grain. So that's basically the same as saying sugar. That's what it translates to in the body. So when you give yourself a lot of grain, a lot of sugar, a lot of carbohydrate, you're hungry. So what do corporations do? You know, corporations are twofold. They want your money, but at the same time, they also are going to do whatever follows the demand. I mean, you know, Coca-Cola, Pepsi, I can say these. You know, they don't only have regular soda, they have diet soda. They have zero soda. They have stevia soda. Why? Because of the demand.
I can't lie, I love Coke.
So I love Pepsi. I'm trying to not.
It's a wraparound thing. So, you know, to your point earlier about corporations, are they just out to just get us? I honestly don't believe that it started that way. I believe that where we introduced processed foods in this country was when we went through a famine and made a decision after the Great Depression that would never happen again. Because like I said, who would die first if we had a catastrophic incident? It'd be the vegans, vegetarians. Hopefully I don't get hate mail. But the people who eat processed food wouldn't, you know, because they've got food that's not perishable. And I say that to make a point, not to bash anyone's diet, but to make that point. What did the United States do when we went through the Great Depression? Well, they created fake food. They created food that had a long shelf life. You know, we sent the soldiers in other countries in Vietnam this food that was in a package. So I don't think that it started as a tactic to make people addicted, but I do think that became, you know, some of the aim over time.
I just see like the cycle of, you know, how the corporations do, and that we're eating these foods that make us addicted, but then when we need, you know, doctors and medicine to help, and sometimes it's not from the space of how can I make you well, but how can I keep my patient, and like I get that there's balance in that, but sometimes it's just really, it's like, it makes me sad because I'm just like, why can't it be that everybody just wants people to be happy and healthy and feel good? And that's just not
ain't
real.
Everybody's motive.
It's not. And there's some people who do things just for the money.
Yeah.
So.
Well, I will support doctors and say this. You know, they follow demand as well.
Absolutely.
If you know, if 50% of my patients come in and say, I don't want to use weight loss as an example, because it does get stigmatized, but they come in and say, hey, I want to lose weight. Well, let's talk about your diet. Well, I don't want to talk about my diet. I want medication. Then you kind of pigeonhole your doctor too. You know, weight loss is one example, but sinuses, colds is another one. People come in for antibiotics. So, you know, and then doctors are reviewed.
Yes.
You know, why are narcotics an issue in this country? I think there's a lot of reasons, but one of it is because of demand. It's because of the people. It's because of the patients. It's not completely their fault, but they're somewhat to blame. Patients put pressure on medical systems and on doctors when they don't get what they want. and they don't always know enough to know what is right for them. We want our patients to be smart and savvy and read and research, but your average doctor has read and researched for 11 to 15 years. You're never going to catch up to them in your knowledge base.
That's true.
Unless you're doing it every day for 12 hours a day, which most patients are not. So, I don't think that doctors intend to, take people's money, give people medications. But when you come in with a blood pressure of 180 over 100, and you've been trucking around like that for the last 30 years, you don't give me a lot of options.
That's really real, because there are a lot of people who just don't want to make any changes. They just want they don't want to do anything to get the change that they're looking for.
Yeah. And we can talk about our community, how many, and not to generalize, but how many of us know someone who says, oh, I don't go to the doctor.
My grandma. Exactly. I can't get her to go.
Most of our, older family members, and some of our younger family members, most of our men, they don't want to go to the doctor. They detest the doctor. And I understand historically some of that does come out of mistrust of the medical system.
Yeah.
However, you can't have it both ways.
No.
You can't say, I'm not going to go to the doctor. I'm not going to get my annual visit. I'm not going to see what this lump is on my breast.
Right.
And then get have an opinion about how doctors just want money, and we're not honest, and we're not noble, and they're just giving me medication. Well, they're giving you medication because you haven't been to the doctor in the last 20 years.
Right.
So now you actually require it.
Right. To function.
Even in weight management, we start with nutrition. We start with physical activity. We start with the basics. We start with understanding the foundation of the patient. However, there are times when I need to go to a medication as well that may not be permanent, and I do a lot of education and explanation for why am I using this medication, what medication I think is best for you. But there are times in obesity where if the risk benefit, if you are 400 pounds, it is safer for you to take a medication than to not take one.
That's true.
Because your physiology is diseased. So, that's an education point as well. People have to understand that doctors really do want to make the best decision for you, and sometimes that is a medication, or it is a surgery, or it is a taking an organ out. I still want to believe that the truth is we actually don't make as much money as the companies. Pharmaceutical companies don't cut us a check. That's a huge misconception. So I don't have a skin in the game.
Yeah. Well, Dr. Covington, we thank you so much. This has been an abundance of information. We thank you so much for joining with us. Can you let people know where they can find you real quick?
So the name of my practice is Abundant Health and Vitality Associates. I know, that was a great segue. I am located in South Park. I'm at 6135 Park Drive, Suite 510, and you can find me on all social media.
Awesome. I'm at Suite 510 too. Did you notice that when you came for the anniversary?
Oh, twinsies.
I did, actually.
Yeah, I just want to say this didn't go in the direction that I thought it was, but I learned way more than I don't know. In my head, we were going to talk about business and all these other things, but this was awesome.
Yeah. Thank you so much.
Thank you.
All right. Absolutely.
Yes,
Absolutely.
ma'am.
All right.